Good afternoon. The session is ready to begin. The session is sponsored by Optum. We appreciate Optum and their sponsorship. Chris will moderate the session, and Chris, you have the floor.
Okay, thank you, Charles. And I would like to welcome everybody to our session today. Good morning, or from here in California, or good afternoon if you're joining us from elsewhere. Our session, Bridging Data and Policy, Understanding and Navigating Data, sponsored by Optum. My name is Chris Krausick, and I'm Chief Analytics Officer with the California Office of Statewide Health Planning and Development, and have the privilege to facilitate the session today. Our agenda includes 3 presentations, each providing examples of data in use to inform policy and decision making. Within the presentations, you'll see the role of engaging end users around data, the importance of transparency while also maintaining security and confidentiality, examples of tools that were developed to increase the use and the ease of use, informing action and policy. And you'll also see some of the challenges of using data, how these were addressed, and the impact of the one landmark decision, Gobay versus Liberty Mutual Insurance, and the resulting impact on data completeness. Our first presenter and our first abstract is going to be Dr. Amy Hahn-Nelson. Amy's with the research faculty and Director of Training and Technical Assistance for Actionable Intelligence for Social Policy at the University of Pennsylvania. Amy will present on a toolkit developed through a collaborative process of engaging stakeholders around integrating data with a focus on equity. Our second abstract is going to be from Sylvia Hobbs. Sylvia is manager for the Massachusetts Center for Health Information and Analysis. Sylvia will present on the demographic differences in claims data, both before and after Gobay, and the impact the exclusion of self-funded employee plans had on the completeness of these data. And then our final abstract is from Dana Richardson and Jim Oren, both with the Wisconsin Health Information Organization, or WHIO. Dana is the Chief Executive Officer for WHIO, and Jim is the Director of Customer Solutions. They will present on a tool that they developed and several of the reports from within this tool that make APC data available to non-technical and non-analytical users of the data. Just a few house cleaning items before we get started. To the presenters and then also others, please keep your video turned off unless you are presenting and your line muted. We're going to do our 3 presentations, and I'll make sure that I monitor the time so that we have opportunity for questions and discussions at the end of the presentations. If you do have a question, I encourage you to use chat, enter it in there so that we can get those in the queue for our discussion session. So with that, I will go ahead and hand things over to Dr. Amy Hahn-Nelson for our first presentation, titled Centering Equity Across the Administrative Data Lifecycle. Amy?
Hi, everyone. Are you able to see my screen?
I'm seeing a black square.
Yeah, you might want to try to stop sharing and then start sharing again. Sometimes when you kick into full screen, it just, there you go.
There we go.
Perfect. All right, thanks everybody. Well, good afternoon. I am located in North Carolina, so lovely to see all of you, or not see all of you, but have all of you on the line. I'm Amy Hahn-Nelson. I am with Actionable Intelligence for Social Policy, which is an initiative out of the University of Pennsylvania. We are a group who focuses on supporting data integration and data sharing with government agencies across the United States. And we provide a range of services. And I'm presenting to you on a product that we just finished, some research that we just concluded and came out this year on centering racial equity throughout data integration. So here's the bit.ly we encourage you to click on, to type that into your browser, find the toolkit. I'm just going to be providing a quick overview for everyone today. So the process is one that's been going on for a while. While it was just released in 2020, the genesis of this process came about many years ago, so back in 2017. And since then, we've been working to put the toolkit together. So we have a range of funding for it. We put together a work group, and then the toolkit was collaboratively generated. And that's really important for what we do and the way that we approach this work. So generally speaking, we like to think of this toolkit as kind of this intersection of racial equity and issues of justice, issues of fairness, issues of equity, and data, right? So usually these two lines of work don't cross very often, and we thought it was important to facilitate some sort of document to provide guidance on how to do that well. So, and this is really important because our current amendment is complicated, right? Like we have more capacity for data use and data integration than ever before at every level of government. But administrative data are deeply flawed, right? The analytic tools we use they're good. They're an improvement on what we used to do for certain, but they're still deeply problematic, especially when you think about how biased data is. So we like to think of this work as infrastructure development, and to continue that analogy, you know, if you look at the history of railroad development in the 1800s, highway development in the 1900s, both of those large nationwide infrastructure projects really either developed or decimated communities. And so we like to think in the same way, right? Data infrastructure is the infrastructure project of our century, and we really have to do it right, or we are going to, recreate history the way that railroads and highways did. So the work group contributors, this was a collaboratively generated document. While I was lead author, I certainly was not lead contributor necessarily. Everyone contributed. It was a very long, wide bench. These are our main work group contributors. We also had site-based contributors that talked a lot about what we call work in action. So everything that you see in the toolkit was based on work that people are actually doing right now. While we think that theory and theoretical ideas are very important, our work is really grounded in work in action and lived experience within agencies and within communities. So this toolkit really focuses on that. So here's the big question. Where do we need to center racial equity, right? At what place do we do this within the data lifecycle? We think of the data lifecycle in this context within 6 stages. So everything from planning for a project, seeking funding, figuring out who's going to be a part of the team, data collection, data access, use of algorithms, statistical tools, analysis, and then reporting and dissemination. So where do we need to center racial equity? And of course, it's everywhere. At every stage of the data lifecycle, it is critical that we center racial equity. Throughout the toolkit, we do spend some time really parsing out what we feel is most important. So this slide that I have in front of you looks fairly simple. We strongly encourage and we discourage. This slide summarizes the work of about, probably 30 hours of discussion with our work group. I like to kid them, kind of not kidding, that we locked them in a room with lots of muffins and coffee and wouldn't let them leave until they came to agreement on data use and data access rules. So that's kind of what this is. So out of our work group contributors, everyone could be okay with these statements. Not everyone was happy or thrilled, but they could get behind these. So we strongly encourage participatory governance, so a wide range of stakeholders making decisions. Social license, meaning that you have a right to these data for access and use. A developmental approach to data sharing and integration. So for example, don't start with predictive risk models. Instead start with just very simple aggregate counts that are integrated, or just simple data sharing before you got to crawl before you run kind of thing. And generally speaking, we discourage broad access to individually linked data. The more linking you do with data, the riskier it is, and so access should be really constrained. We generally discourage data use around enforcement or investigation actions against residents. Use of predictive algorithms, we have concerns about, and then use of data across institutions with patterns of institutionalized racism. Funny enough, when we first put that statement in here back, 8-9 months ago, that was a really contested piece of the toolkit. And now, with the social unrest and the norms around the understandings of bias and discrimination, institutionalized racism, this really isn't that far out there anymore, is it? All right, so throughout the toolkit, we like to think a lot about balancing these risk versus benefit. So we, of course, are enthusiasts about data integration. Some would even call us evangelists about data integration, but we think that you should only integrate things where the benefit to risk ratio is a good idea, right? So if there is high benefit, low risk, great. If there is high risk, low benefit, then we would strongly encourage you to put a lot of discussion around that and make sure it's a good idea. And if it's not, then you probably shouldn't do it. And we think a lot about what type of data should be used in this toolkit and also just in our data sharing work that we lead. So we spend a lot of time thinking like what data should be open. People who don't know me well think that I'm a big open data supporter. I'm actually not. I think a lot of open data should not be open. I think that we have opened maybe a little too much data. And so we walk through that in the toolkit a little bit. Sometimes we need to walk back from open data, and then sometimes we need to release data depending on what the goals of that data and access and use are. Restricted data is data that can be used if you're a credentialed user and have a reason to use that and make it actionable. And then there's some data that's just unavailable, and we go through that in the toolkit as well. That could be unavailable because it's legally not permissible, or in some cases, it could just be a format issue. All right, so the way that the toolkit is organized is across the 6 stages, and in each stage, we present positive practices, problematic practices, and then there is a work in action. So for example, this is one stage, and don't worry, I'm not gonna walk through all 6. In this stage, we walk through very specific examples. So in this context, so for example, a positive practice would be including diverse perspectives, such as maybe community members. We often talk about like people who are in the data, right? Families, individuals who are represented in the data. And then the corollary problematic practice would be, using only token representation in that context. For each stage, we have these listed out. And then we also have a summarized work in action, so fairly short, and then the long form for those of you who like the appendix reading, we have long form work in action as well. All right, so, and just as a reminder, what I just showed you, that is for all 6 stages. We also have toolkit activities within the toolkit. That there are several different things to like walk organizations through on how to center equity, racial equity, and ways to do that effectively. But here's, if you think about one thing, as I get ready to wrap it up, the biggest takeaway on centering racial equity is no matter where you are in an organization, a data owner, a data steward, a data custodian, a caseworker, no matter where you are, there is something you can do today to center racial equity. There's countless ways to approach this work and countless ways to jump on in. So this is a place where you can't have, perfect be the enemy of good, right? You've just got to get started, take one step, and then keep on walking. So we hope that you will follow this work. We are continuing to do a lot of work in what we're calling the 2.0. So this initial toolkit was our 1.0 as we try to learn what people are doing and disseminate best practices. But this is going to be a continual process, and we already have a pretty good list of things that we'll update this document for as we continue to move this work forward. So will you join us is the question. And here, if anyone has any ideas as we work on version 2.0, this bit.ly is AISP Toolkit feedback. We are soliciting kind of responses to the toolkit, ways we can make it better, or ways or ideas. Maybe you are doing work in your organization that you would like us to highlight, and this would be a great opportunity for you to tell us about that work. All right, thank you so much. Here are the bit.ly links for we actually have 2 parallel documents. One is the toolkit, and then there's a data integration document that is also listed there. And I know that we are going to stop here and go to questions in a few minutes. Thank you.
All right. Thank you, Amy. Again, just a reminder, we are going to go to questions, but we're going to hold those until the end of the 3 presentations. So I'm keeping an eye on chat, and if you want to enter those into chat, I'll make sure that we have them ready for our discussion section. For our second presentation, I'm going to hand it over to Sylvia Hobbs, the abstract titled Demographic Differences in Claims Data Before and After GoBay. Sylvia?
Okay, I'm sharing my screen. Right. This presentation focuses on differences in the APCD before and after GOBAY. Most applicants, especially the academic researchers, are generally aware of the published preemptive effect of ERISA, which regulates employee benefit plans, the impact it had in GOBAY versus Liberty Mutual in the 2016 Supreme Court case, which superseded Vermont's APCD reporting requirements. As a consequence, in Massachusetts, at the end of 2017, approximately 1.75 million self-insured beneficiaries, that's 75% of the self-insured, were no longer in the APCD. Prior to GOBAY, a frequently stated scientific rationale by researchers for applying specifically for the Massachusetts APCD was that in 2006, the Massachusetts healthcare reform law resulted in nearly 98% of Massachusetts residents having healthcare coverage. Consequently, the Massachusetts all-payer claims data represented a unique foundation for empirical research demographically representative of the entire population within Massachusetts geographic boundaries. And I want to emphasize how important population-based, specifically from the perspective of the APCD. One of the very first R01 grants submitted to the NIH using an all-payer claims data was submitted by Dr. Wenjin Lee at UMass, and this grant application received one of the highest scores ever. It was pre-GOBAY using the APCD for trauma disparities analysis. So in the figure 1 here, you can see how closely the pre-GOBAY data and Massachusetts all-payer claims data align with the census estimates for 2014. They're pretty close to each other. Let's change. Questions raised by applicants in the aftermath of GOBAY. Even though the applicants are aware of GOBAY versus Liberty Mutual, a common question asked is, what is self-insurance? And we explain the process where employee assumes the risk. We explain ERISA, and in answering these questions about what is self-insurance, there are instances where the applicants themselves become aware that their very own institutions have a self-funded coverage plan, and they are potentially in a position to explain to the carrier handling their product the utility to the applicant institution of having their data submitted to the all-payer claims data. One of the benefits specifically to academic institutions and other hospitals, government agencies who partner with them is the potential to receive millions of dollars in research grants. As defined by the Bureau of Labor Statistics, and some of you probably already know this, the concept of self-insurance is a self-funding coverage mechanism of the employer-sponsored health insurance plan where employers directly assume the major costs of health insurance for employees. And I'm describing this difference because some data users confuse self-insurance with copay and other things, or self-insurance with uninsurance. And it's important, especially if the applicant institution is one using a self-funded plan, that they understand what that is so that they can be proactive in interacting with their carriers, potentially to get their data back into the all-payer claims data. Applicants ask, given this impact of the reduction of self-insured in the Massachusetts all-payer claims data, how do we identify the self-insured in the APCD? We have a data field called the APCD ID code, which is available in the eligibility file, the medical claims file, the pharmacy claims file, and also the dental claims file, which allows data users to stratify by different enrollment types. And there is a category, specifically category 2 for the self-insured. There are also in the member eligibility one field which allows you to drill down and look administratively whether the self-insured product is being handled by a third-party administrator. We explain in our release document the Supreme Court decision, how it severely reduces the data starting in 2016. Consequently, some applicants ask, how severe? Yet other applicants, once they receive the data, will nevertheless ask, why are the data missing? Is something wrong with the extract? Can you re-extract the data and send it to us again? I wish re-extracting the data would put these self-insured back, but it doesn't. For applicants who have been approved to receive both the private and public payer data, the impact on medical claims volume is less severe. As you can see in figure 1 here, doing a medical claims line count, the overall impact after GOBAY is a 15% decrease. But for those who are doing research only using the private commercial claims, the impact is more dramatic. It's a 27% increase in medical claims line. I'm talking about claims line now, not individuals. I'll get to that. During the application review process, some proposed study plans are found to focus on specific demographic groups. Data applicants ask, how does the 75% drop from 2.3 million self-insured in the APCD before 2016 to 563,000 in 2018 impact my study? Does the impact of GOBAY on the population distribution differ by specific age, gender, geographic levels? How should I describe my study's denominator? Does the impact of GOBAY differ by care setting? Should I use the administrative case mix data instead of the MAPCD? Should I use the administrative case mix data instead of the APCD? And they're specifically for people who are applying to use inpatient care, do inpatient care data analysis or ED analysis focusing only on Massachusetts, the case mix data is still their best game. But we still, no matter what, we send in advance before the application process, we make sure that the applicants are informed about GOBAY. In addition to sending them links to our release documents, we send them links to all of the wonderful work that Friedman has done on GOBAY. Here, when you look at, in these figures, when you look at the census population estimates before GOBAY in 2014 and 2015, again, you can see the close alignment between the population count, the actual beneficiaries in the Massachusetts APCD, and the census estimate. After GOBAY, you see a drop by age group, but here these counts include the public payer. Even though you see the drop, it is less pronounced when you include the public payer data. However, when you remove the public payer data and only look at the commercial private data by age group, you can see the dramatic differences pre-GOBAY and post-GOBAY. In the top figure here, I'm comparing pre-GOBAY 2014 to pre-GOBAY 2016. In the bottom, pre-GOBAY 2015 to pre-GOBAY 2017. The differences by age group are pretty consistent doing the two comparisons, and in both instances, the highest difference, even though there were a smaller number of people, happened to be for the pediatric population. The difference was 40%, and lowest for the senior population, 65 years and older. And so this difference can impact studies that focus on the pediatric population. I will show you an example. This is a specific study of an applicant who applied for the for a report generated from the APCD looking specifically at outpatient pediatric asthma visits in the population ages 2 to 17 years old in 2014, pre-GOBAY, 2015, pre-GOBAY, and 2016, after GOBAY. And if you look at the public insurance for each year, you see the asthma visits going up, but they're within the same range each year, pre and post-Gobet. But if you look at the private insurance in the years pre-Gobet, 2014 and 2015, and post-Gobet, it really hits home. You see the dramatic drop in claims. And it's really important that researchers understand this so that they will know that asthma's gotten better, that they will understand how to adjust for this difference. In evaluating the total volume of member-link EIDs, this is a distinct EID that we probabilistically create so that researchers can do analysis across carriers in the eligibility file for self-insured enrollees. Regardless of state of residency, the percent drop for females from calendar year 2015 to calendar year 2016 was 68.1% versus males 68.4%. State of residency did not meaningfully impact the differences between males and females. For Massachusetts residents, the decrease was 56.9% for females versus 57.7% for males. For non-Massachusetts residents, the decrease was 91% for females versus 91.3% for males. The important take-home lesson here is the difference doesn't vary by gender, but the drop is dramatically high. In looking at Massachusetts residency, although the volume of Massachusetts residents in the MAPCD remains higher than non-Massachusetts residents, a distinct count of member-link EIDs in the member eligibility file stratified by Massachusetts residency and non-residency using the APCD ID code reveals a larger proportional drop in the self-insured of non-Massachusetts residents than self-insured for Massachusetts residents. And as you can see in the table in figure 1 below, you see that enormous drop in residences versus non-residents. And this drop is significant because one of the values of using the APCD versus the case mix data is in some instances when you're analyzing interfacility transfers, patients just fall off the radar in the case mix data because the case mix data only includes acute care hospitals in Massachusetts. They do not fall off the radar in the APCD. You can see whether a pediatric patient was transferred to Rhode Island Hospital. You can see the bouncing back and forth of ambulances and air medical across state boundaries, and that's one of the beauties of the APCD that may have been that was diluted. So for each pre-Gobet year, the percent total difference between the Massachusetts population and census estimate remain less than 2%. And we have some researchers still holding on and reapplying to use their pre-Gobet data because that remains the holy grail. Post-Gobet, the total population difference between the census widened to 24%, and the percent post-Gobet decreased by the self-insured enrollment type was highest for non-Massachusetts residents. The magnitude of decrease between males and females was not meaningful, but both equally severe and high. Applicants should be warned of the pronounced age group decreases and how population level deficiencies impact a fully representative count routinely used for epidemiologic surveillance. So in conclusion, future efforts to maximize the post-Gobet utility of all payer claims data should continue to assess variation in population decreases at the geographic and age group level that may impact the magnitude of expected population counts for specific types of targeted demographic studies. And I'm telling you this, how important it is, because we have had students propose their doctoral dissertations with the expectation of getting population-based data, and they have to change their thesis topic and change the repository in some instances from APCD to CaseMix. But APCD is still of enormous value. The care setting for data use should be assessed so that the applicant can understand the differences between the APCD and administrative CaseMix data. Applicants and their institutions are in a unique position to influence carriers to participate in submitting their data to the APCD. People are always asking me, what is the workaround? What is the workaround? What is the workaround? And it's kind of ironic if they're from an institution that's a self-funded plan that's not submitting their data. It's not, for them, it's not a workaround, it's a work on. You have the clout to ask your carrier to submit their data to the APCD, and your institution, which they are working for, will benefit from that. And there's my contact information. Thank you.
Okay, thank you, Sylvia. And for our third presentation, our final presentation, we have Dana Richardson and Jim Oren, with Jim actually being the primary presenter, just to not overwhelm the technology here. Their abstract, Empowering Non-Technical Staff with Access to APC Data Through Applied Insights. Jim, floor is all yours.
Thank you. Hopefully everybody can see the screen and hear my voice. Thanks for inviting us to participate today. Dana and I, of course, are with the Wisconsin Health Information Organization. We pronounce the acronym WIO. And this slide, while many include these sorts of slides in terms of who we are, this is an important one for the context of our comments today. WIO is a voluntary multi-stakeholder organization, all payer claims database. We do have participation from state agencies, payers, providers, researchers use our data, but our revenue is primarily and predominantly from the provider sector in terms of how we support our efforts. We have not in recent years had a consistent source of either academic or public financing for our operations. And so some of the context of what we're presenting on today is really in this area, the voluntary nature of our APCD and those who are involved in the organization. And one of the principal things that we are asked to do and challenged to do is to demonstrate value in the use of our data in return for the financial support we receive. Today, we're going to present, and I have a few slides in terms of a web portal that we've created that make our data, our APC data, a little bit more consumable to non-analytics users. And some of this came from feedback that we received as part of a planning process to update and upgrade our data ecosystem and our products over the last several years. In particular, two are highlighted here. In Wisconsin, we do have smaller organizations interested in using our data. And there was certainly interest and ongoing interest in asking if there were analytics or presentations or visualizations that WIO could perform or complete for us. And even larger organizations who are making use of our portal nevertheless are interested in some of our summary reports so that they can, free their analytical staff, their very busy analytical staff, to work on other priorities. Keep in mind, WIO is a comprehensive claims data source for Wisconsin. We receive claims from about 14 or 15 commercial health plans, as well as the state Medicaid program. We have about 4.5 million covered lives in our database. So a few items about how Wisconsin is unique, at least from our perspective, among APCDs. So we don't have any dominant health plans in the state. We do have large ones with presence. There are 3 significant national health plans in the state, but unlike some states, including actually a couple of our neighbors, the distribution of membership and enrollment is really across a number of small to large regional health plans. We do have self-funded employers in Wisconsin in relation to the prior presentation, and some do voluntarily submit their data to WIO in a couple of our major metropolitan areas in particular. There's a few items here that I won't go on in terms of how of how Wisconsin is unique demographically, but a couple that I would highlight is that while we do have a couple of larger urban areas, of course, the Milwaukee area, Madison, and to a lesser extent, Green Bay. We are a very rural state as well. There are large geographic areas in the rural areas. And, you know, the last one, you know, perhaps we drink a lot, we weigh too much, and we eat a lot of beef and cheese. So, so while the characteristics of the data we receive, the plans that we receive it from, and the data elements that we receive are very similar to most APCDs, we received quite a bit of feedback from users and potential users in developing a different approach to using or accessing the data from the traditional data file. Now, I want to be clear, we do also offer data files as well as data extracts. So that continues to be a route to the use of WIO's APCD data that is available, and some organizations do take advantage of that. Others, though, are interested in a web-based portal that we have built that hosts Tableau reports. And the target audience for some slides that I'm going to show you here are really for those within mostly healthcare organizations, in some cases others, who are strategic planners, marketing and business development folks, chief medical officers, department managers, those sorts of things. And we were really asked to and wanted to deliver on access to APC data that would be essentially IT free. With this portal and the reports that we have built, really all our users need is a working web application and internet access. We provide that to them. We provide login users and accounts. And I'll highlight a couple of these other bullets and a couple of screenshots we have coming up. So one of the significant value adds that we have built into the portal is the ability to display or unlock my data compared to Benchmark. And so the portal leverages a security mechanism to recognize my organization upon my login, and then display, as I say, my data versus benchmarks. And you'll see that in a couple of screenshots coming up. We also have, again, through customer feedback, standardized some commonly requested filters across reports, patient demographics, time periods. Product sector is one that is very commonly requested and is of interest. And then we have built in common aggregations of procedure groups and drugs. So this is an example of one report that, that we received feedback and were requested to build. This is in Tableau, for those of you who are familiar with that tool. Essentially what this report does is, through pre-processing of our APC data, identifies and assigns patients or imputes them to providers and their health system. This report then takes that population of patients who have been imputed to, quote unquote, my health system, and illustrates where else those patients are going for the indicated procedure that is displayed on the left. So essentially, as an outmigration, this report says, well, these patients are ostensibly those that I am responsible for caring for, yet they are going to these other 2, 3, 4 health systems. We've kind of got it blinded here with the gray screen box on the left for these sorts of care. On the right, you see the common filters that a lot of our reports have. Procedures are grouped up into the CCS grouper capability. There are drill down capabilities that let you get down all the way to the CPT procedure code. And then, you know, patient demographic and product sector are also filters that are here. But this, again, in response to, you know, user feedback, allows our health systems in particular to identify who their strategic partners are or should be in providing comprehensive care to patients. We've also built an opioid prescribing pattern report. And again, this gets down to individual provider display, but it leverages the pharmacy data that we receive as an APCD to determine trends, days supply patterns, fill rates by drug, and volume of claims by specialty and provider for a health plan, for a health system. This, just like the prior slide that I mentioned, is a great example of leveraging the security mechanism that I mentioned we built. So upon login and opening this report, it displays to me as a health system user those physicians who are within my health system. And only I or my health system users can see that physician level detail. But it allows users, again, by request, feedback that we receive from them to track and identify variations in opioid prescribing. This is kind of a mashup of several different views of some key performance indicators that we've built. This provides average length of stay and admits for inpatient care, their emergency department metrics, ambulatory care metrics, and advanced imaging metrics. All of the colored bars that you see in this illustration would be me or my health plan or my health system, with the narrow vertical bars then being benchmarks with which to compare our utilization trends. This screenshot doesn't have filters, but this report does include many of the same filters that you saw on prior screenshots. We have built a Population Explorer application within this portal. Essentially what this application does is, with some quick drop-down boxes, that allows you to choose a file type, medical or pharmacy, product sector, commercial, Medicare Advantage, Medicaid, time spans, and then you can see with the illustrated drop-down box a variety of pre-built clinical populations that have been built into this application. And once a user makes these selections, they can download an access file of all of the detailed claim line records for patients with these clinical markers in their claims records. The file includes all claims associated with that patient, not just those with, for example, diabetes on the claim line. And this has been, again, through feedback, something that was of considerable interest. Doesn't really take any particular IT skills to operate this Population Explorer and file download application. That was the last formal slide I had to present, but I wanted to emphasize, I guess, a couple of things. One is the reports that we displayed here today really take hundreds of millions of medical and pharmacy claim lines, eligibility information, and other data from, a dozen to 15 health plans in the state Medicaid program, and summarizes them or packages them up into easy to consume reports via a web portal for which our users really require nothing more than an internet access and an account. And they've been of considerable interest by our users because of the ability to extend the access to our APCD data to people who are beyond or who are not in the sphere of SQL analysts, researchers, and and IT data analysts. We have those as well, but this is an additional capability that we have leveraged. I'll stop there, I think, and invite the next stage of questions. I will note that this slide deck that we have included does include some appendix slides, because I do know Norm and NATO are making the slide decks available for your viewing later. So there are some additional slides that we won't go through today. Thank you.
Thank you, Jim. So been keeping an eye on the chat and have not received any questions via chat yet. So I'll go ahead and maybe kick things off for the discussion with a question for Amy and Jim. Your work was particularly focused on the end users of the data and creating tools and information through a considerable amount of customer engagement. What were some of the key insights beyond what just you highlighted, or in addition to what you highlighted, or even taking them a little bit further, that you gained by working directly with the end users? And how did that engagement change or impact the directions that you went with your tools from kind of as you had initially conceived them and where they ultimately ended up?
Okay, thank you. I'll jump in first. What's interesting to me about our build of this capability is that it doesn't, and I know I stated this a couple of times in my presentation, but it is not to the exclusion of the availability of data extracts and files. So we provide those as well. And this we really saw as an expanded capability. It was something that as an organization we had always wanted to do. In a prior iteration of our capabilities, there was an older web portal to our data that was provided. We thought that we would want to update it. But I guess specifically to your question in terms of what the feedback process was, it was very interesting because it is typically very different from the data file or data extract side from researchers. My perspective is those users usually know their way around data and have a pretty precise sense of what they're looking for. You certainly need to look and work with them to refine those requests. But in the case of a portal with visualized Tableau reports, there's a lot more iteration, and I guess I would say really, and in a good way, customer feedback in terms of what you're trying to accomplish. There is, I would say there is less certainty on the part of users of, at least at first, precisely what they're looking for.
Chris, it looks like you're muted.
Thank you. Amy, your turn.
Yeah, I can check that off my bingo card. All right, I didn't really make a bingo card, but I do sometimes for these things. Yeah, I mean, it's a little different. We had a little different process. So I probably should have done a better job in my presentation framing out what AISP is and kind of what we do, because we're not directly, I think we're a little different from a lot of NATO involved organizations, because we're not just healthcare. So we specialize in cross-sector data integration and data sharing. And we mainly support government agencies, but we also support a lot of nonprofits. We don't do as much private industry work, But because there's this blurring, right, between private and public now, we do work with a lot of vendors. So the Centering Racial Equity Toolkit was really important because it attempted to kind of bring all these different stakeholders and perspectives and lenses together in a room and kind of make them come to some, we call it like public deliberation, right? Like come to some sort of agreement on what should be best practice, because there just aren't any best practices around this. And what I would say, like the biggest takeaway was that everything depends on site context and on where you are and what are the challenges of that site in racial equity and also in data use. So some communities, some states, some counties, some cities have really advanced analytics, right? Some have really advanced data management. Some have neither. A lot have neither. Everyone's got different levels of this work. But racial equity is something that is very new to the majority of data custodians, for data owners, data stewards. These aren't, there's not a depth of content expertise around this intersection. So I would say the biggest thing is to try to start small and keep on going, but mainly just to keep on going. That was probably the biggest takeaway, was that there's something for everyone, and that something looks really different. There's no magic bullet. There's no one approach. How you do it can be individualized a million different ways.
Great, thank you. Thanks, Amy. We did actually receive some questions in chat, and I'm gonna start off with one that was specifically for Sylvia. And the question is, has CHIA had any success in acquiring voluntary submissions of APC data? And what have been the reasons for success and the barriers? So Sylvia, you want to take that one?
Yes, there are some carriers that have, first of all, our submission of data for all the carriers is mandated by state law, and the point of the presentation was that GOBAE superseded state law. Nevertheless, some large carriers did continue to submit their data, and we believe the reason for that is they understood the utility of the data. What's puzzling is that the carriers who withdrew their data still submit other types of products. So it wasn't that the infrastructure didn't exist to collect that data. I was kind of puzzled in looking at the Supreme Court decision, because all of the letters submitted asking that this data continue to be submitted to states provided every possible argument on the need for that data. And the justice, one of the justices said something that claimed that the Department of Labor was institutionally incompetent when it came to data collection. I don't agree with that, though I can't unsay it, because in a court, the judge would hit on the gavel and say, jury, ignore those comments. I think federal agencies are in the same position as state agencies, where they try and collect data that is administratively useful. I think it will be helpful to the states and to the carriers to work with the Department of Labor. And this was something that Friedman has already suggested, on having a standardized data set so that it wouldn't pose an administrative burden to carriers to submit that data. We've done that, so I think there still has to be pressure on the Department of Labor to have some stipulation that this data go to the states. I think the carriers understand that, but there's still work that can be done by institutions that apply for the data, and they are covered by self-funded plans.
Thank you, Sylvia. So we have another question that came in, and it's for all of our panelists. And the question is, can you speak to any challenges around identifying the correct provider information? How about hierarchies within provider data? So there's actually two questions there to any of our panelists.
This is Jim at WEO in Wisconsin. So it is challenging, and I obviously the questioner probably knows that. A lot of the characteristics of providers, of course, are not a native element on a standard claim form, whether pharmacy or medical. So what we have done in Wisconsin is develop our own provider registry, so to speak. It is really an ongoing, never done, active process of continual updates via two primary mechanisms. One is active involvement and conversation with our health systems to provide updates to us in terms of provider affiliations, changes to rosters, added specialties, those sorts of things. And we also bring in data sources like NPPES to supplement it. We target, in terms of the priority for keeping our provider registry updated, those who, of course, have the largest volume of claims data and who are otherwise unaffiliated within our registry. The last thing I would say is, and if anybody has done better than us, then I'd like to give you a call. It's not perfect. It is not 100%. There are still providers in our registry that that we have not been able to identify an affiliation for. Although I would say we actually do quite well for Wisconsin, where we tend to spend, frankly, a little less energy. Our providers in our system for that patients have seen while traveling, for example, in another state quite some ways away.
I think it's going to come down to, and this is in the future on SHIA's radar, to create a master provider index. And some of that is going to be driven by the volume of claims associated with different institutions. And also, in the same way that we have a member entity identifier, the quality of demographic information on an individual, and trying to weigh information from CMS and also from our own state licensing database. But it is a challenge.
Yeah, and I'll just add to what Sylvia is saying. As far as hierarchies within provider data, specifically around race and ethnicity, it's really important to make sure that you know how that data is collected, because there's some administrative records that may, if it's input by a case manager, for example, it may be phenotype, like what someone looks like, versus a form, it's going to be self-report, right? And also we know that race, ethnicity, and identity shifts. So, the way I identify myself racially and ethnically today may be different in a couple of years. We know that these identities are very fluid. And so it's important to capture that piece of self-identity. And we generally recommend really having honest discussions about how that data is collected, and then kind of picking a golden record. If it's the self-report source, use that one. If it's one that's reported by an intake counselor that's not a conversation, then probably don't use that race and ethnicity data.
I had a question for Amy. Amy, do you see in the future the possibility of people including in their claims data DNA test results on what their race and ethnicity are?
I am not speaking as AISP right now because we have never had this discussion, but I will say, me personally, I hope that is not the case. Because race is a social construct, right? DNA has nothing to do with it. All DNA can tell us is the geography and maybe geographically where someone comes from, and that has nothing to do with identity or the social construct of the experience. Yeah. So I would say personally, yeah, I hope that doesn't happen.
Well, just
but again, that's not.
Just on the ethnicity construct, because we've noticed with the increase in DNA tests that some people, as you mentioned, are changing their race and ethnicity. They're one thing in another care setting, and another thing in another care setting, and another thing in another care setting. And we think that may have to do with they've had a DNA test and they see that they're everything.
Yeah, I mean, it's fine. And we know even before DNA testing, these things are fluid, right? Census data tells us that. You can go back to census from the 1900s, and that's a whole, and there are books about this. So I do think it's really important. My general rule of thumb is like people should identify themselves. We should not be categorizing people. If people, you know, how people, whatever their primary identity, the way they walk in the world is the way that our administrative data should be organized.
But we still need a standard, because one of the reasons some states do not release the APCD race ethnicity data, because some of them had recorded Klingon, yellow, and other things that are not typically used in
they need to be helpful. Yeah. I'm talking from a policy perspective. Yes, we have to have distinctions that are helpful in making relevant policy decisions. But the data has to be analyzed, you know, and disaggregated, right? So.
Excellent. Interesting conversation and back and forth. We are, unfortunately, at time. So I want to thank Amy and Sylvia and Jim for the presentations. I want to thank the folks that submitted questions. I again want to thank Optum, our sponsor for today's session, and thank everybody who joined us for our session today. I believe I do need to hand it back over to Charles for just one last announcement before we fully adjourn. So, Charles?
Yes, thank you, Chris. Back in Excel events, you'll find a link to a session survey. We ask that you fill that out if you can. And then also back in Excel events, the daily puzzle meetup is starting right now. If you're in the lobby in the feed, you'll find some more details from Norm about where to find the puzzle and when to turn it in. There's a prize involved. So thank you. Have a nice day.
Thanks, everyone.